Deuk Majan. We're here at the Surgery Center of Viera, Deuk Spine Institute, and it is August 15, 2019. For those of you joining us, we've already done one Deuk laser disc repair on a workman's comp patient earlier. We're doing a second Deuk laser disc repair now on a different patient, and this patient's already had a spinal fusion. I did not do their spinal fusion, otherwise they wouldn't be getting another surgery if I had. Unfortunately, they had a spinal fusion done without interbody cages or interbody reconstruction. And as a result, they still have herniated discs at L3, 4, 4, 5, and 5, 1. They don't have a fusion at 5, 1, but they have a fusion at 2, 3, 3, sorry, at 3, 4, and 4, 5. And so, unfortunately, the surgeon, 2, 3, 3, 4, 4, 5. The surgeon did not take the discs out, and the discs are the source of pain, so this patient still has pain in the back and leg. All right, we're going to get started. Our patient is awake. Sir, it's Dr. Deuk Majan. I'm here. I'm going to get started. The first thing I'm going to do is see if you're comfortable where you're laying. All right, now, you're awake for the beginning. We're going to put you to sleep soon, but I notice you have a lot of scars on your back. You've had prior fusion surgeries, right?
Multiple.
And I notice you have other scars here that are not part of a fusion. They look like a spinal cord stimulator.
Correct.
Was that taken out?
I've had 2 put in and 2 taken out.
2 of them were put in and 2 of them were taken out. Any of them at Deuk Spine Institute?
No.
I didn't think so. None of them were at Deuk Spine Institute. It's unfortunate. You've been through a lot because of your back injury.
I have.
Yeah. Well, hopefully this will be the last surgery you have to have.
I hope.
So my hand is on your back. I'm going to give you some numbing medicine, okay? Once I numb you up, we're going to get started. It's real important that you lay still and don't move around, okay?
I'm good.
So if you want to move, this is the time to get comfortable. Are you comfortable?
Good to go, Doc.
All right, sir. We'll keep you awake for about 15 minutes and then we'll put you to sleep. So just going to give you a little bit of numbing medicine. You'll feel a little stick and burn. Are you ready? All right. Now, if you feel discomfort, just say ouch to me and I will give you more medicine to numb you up, okay? I promise. Don't be shy or bashful. And if you have a question for me, you're welcome to ask. We take questions from our internet audience, our operating room audience, as well as our patients sometimes. All right, we're going to get started. Remember, if you feel discomfort, you just say ouch, and I will do my best to make it feel better for you, okay? So what kind of problems have you been having since your spine surgery? How many spine surgeries have you had? Don't include the spinal cord stimulator. But
I had cervical fusion and 2 lumbar fusions.
cervical fusion and 2 lumbar fusions. That's correct?
That's it.
All right. And why did you have 2 lumbar fusions?
The first one's back in 94, work-related injury.
First one was 94, work-related injury, AP. Okay.
Went back to work full strength after that and suffered a second work injury in 2007.
Got it. And the one in 94 that you had surgery for, lateral, was that that was a successful surgery? You got to give me a little bit more room. That's fine. We're good. All right. And the second spinal surgery was, you said, in, what was it, 2004?
Second was 2007.
2007. Okay. I need the table down a little bit. A little bit.
The original injury was 2007. Fusion work was 2011.
All right. Let me know if you have any discomfort, okay? So, I'm coming up on the L5S1 disc. Shot. Shot. Is that the best we can do at 5-1? It seems like we're not lined up with the end plate. Can you wag it a little bit and get me better end plate lineup? So folks that are watching, if you watched a lot of these, or even if you haven't, it's the other way, take a look at those big screws and rods that are in there. Those are from his prior surgery. And this gentleman has been through, it's better, has been through 2 fusions already. And you can see that the surgeon that did the surgery never took the discs out and never put spacers in like they're supposed to. So he's lost the curvature at 3-4. He's got decent curvature at 4-5. Let me see if you can get that a little better. So the needle is aiming for the L5S1. I think we're pretty close. Shot. Let's turn the music off, please. No, I think you can do better. A little bit better. I would. I mean, you're very close. Shot. That's probably going to be the best you can do. That's really good. Let's leave that alone. I think that's the best we're going to get. Are you comfortable, sir?
Yes, sir.
Shot. All right. Let's go AP. So obviously I've got all that hardware. I've got to navigate around. I've got arthritis, and there's something else that he has that's actually makes the surgery a whole lot harder. He has what's called a fusion mass. A fusion mass. And what that is it's all the bone that he's got on the sides of the spine. And that bone is actually trying to block us from getting to where we need to go. Okay, I feel like we're a little bit too lateral, so I'm going to have to reapproach this. Shot. Let's go lateral again. Are you comfortable, sir?
Yes.
So I was just talking to our audience and making note of the fact that there's really a lot of bone that the surgeons caused to form during your last surgery. Shot. And that bone is off to the side there, kind of right where we're passing by. So I've got to work through that bone and scar tissue to gain access to the disc where the herniation is at L5S1. And sometimes that bone will deflect the needle and make it go too lateral. Shot? No. I'm going to have to try a little bit different trajectory. Shot? I think I'm going to have to start a little bit more north. Let me know if it's hurting you, okay?
Okay.
Shot?
Slight burn with pressure, but I can do it.
Yeah, just if it's bad, let me know. You're going to feel some stuff. It's normal to feel that stuff during the procedure, but I don't want you being really uncomfortable. Shot? So that's the fusion mass I'm feeling right now. I really think, Luis, because of that angle of the disc, that we're going to have to start a little bit higher. Huh? Yeah, we're still numb up here, but if I have to go any higher, then shot. Now, I wonder if we can turn the light just a little bit so I can see the monitor a little bit better. Are you still in the same position on the fluoro? Good. Shot. A little bit lower than I want to be. I hope I'm not being deflected. Shot. That's better. Shot. Let's get an AP. I'm about a centimeter away, maybe a centimeter and a half from the back of the L5S1 disc. His L5S1 disc is not fused. He had a 2-3-3-4-4-5, but 5-1 was left. And hopefully we can get in there. That's what I'm expecting. You feeling anything? Huh? Shot?
A little bit of pressure.
All right, let's go with a lateral view. So part of the problem is we have no spinous processes that we can use. And he's not just damaged the disc at 5-1, but he's also rotated. So we can't really use the normal landmarks that we would normally use, like the spinous process, because he's had a laminectomy. Shot. And, but I feel pretty good. Anything in your leg?
Not yet,
Well, let's keep it that way. Shot. AP. All right, so I feel like I can feel the disc herniation right now. I'm in the neuroforamen at L5S1. I think this is probably going to be the most symptomatic disc of all three. Are you comfortable? Where do you feel that?
right leg all the way down.
All the way down your right leg. Better?
Yep.
All right, that's what I needed to know. Shot. Lateral. That pain is gone, right?
Correct.
That's where we are. Shot. Shot. So I can feel all the scar tissue from the prior surgery as I'm passing through. Shot. Shot. It's just lower than I want to be. Shot. I can feel that his bone right there, the fusion mass. Shot. And the fusion mass is pushing me south. Shot. It's redirecting me. Yeah, it's all that dark stuff. You feel anything?
Nope.
Oh, I'm gonna have to start higher up. Num. Yep.
Hold my head.
You're fine. You can move a little bit. Not a problem. So the hardest disc for me to get to is going to be the bottom disc, I think. And that's what I'm trying to do right now, is get to that disc. Just so you know what we're doing. Shot. When was your last fusion, you said?
2011.
2011. Where was that fusion done?
New York.
Shot. A neurosurgeon in New York? Shot. See, it keeps deflecting me. Shot. You know what I mean? I feel the bone mass right there. Let's see if I can go a little higher. Shot. That's better. Let's see if I can just, it's really The terminology is a needle jockey shot. That's better. Let's see if it just pushes me wide. Shot. Let's get an AP. I mean, right now on the lateral view, it looks good. Luis, you got to figure out where to put this table based on where I'm standing, okay? Not this, that. The one I keep hitting with my back end. Alright, so we're close. Are you comfortable? Wow, that's hard. Where do you feel that? AP? AP? No, is that a new picture? Because that looks like the same old one. That's a new one? Alright, lateral. That's our lateral there. Shot. You feel anything there? Alright, I'm gonna have to come even higher. Shot. Can we drop the table just a little bit? And you're too far north. I gotta see L5S1 better. You gotta just center that. I don't know why it's at the bottom. Let's go. Alright. When you're at the bottom of the image, you gotta let a parallax. And we don't want parallax. Parallax will really throw us off. Shot. And we need all the help we can get right now to get this. You feeling anything? I'm sorry? Slight burn in the back? Shot. Just the back, right? I mean, he's got short pedicles right here at 5. All right, AP. Our lineup looks good. I just may want to bring it a little bit lower. Go ahead. All right. Let me know if you feel anything, any discomfort. Shot. That pain that was going down your leg, is that gone? It lateral. Huh? Gone. You don't feel it again? Is that where you grew up in New York?
Yes.
All right, so you can see the challenge here, obviously, folks, is I'm going into an area that's been operated on multiple times, so a lot of scar tissue, a lot of abnormal anatomy, and I'm fairly close. I think. Anything?
No. There you go.
Where?
Take one down the right leg.
All the way down.
Yep.
Shot. That's it right there. Did that go to your toe or your heel? Interesting. Let's go AP. So I'm thinking S1 nerve root, which would be medial, but I'm not medial. That's the only problem. Of course, nobody's really a textbook case, right? So it's probably L5 if you look at where the pedicle is. I need to be a little bit lower. So I'm going to try to go a little bit lower. But I feel all the scar tissue and I can feel the bone. Shot. Shot. And where do you feel that?
Right where you're pressed, right
In the back, right? Lateral. Lateral. It's lining up nicely. Still in the back? All right, hang in there. That means I'm going through new territory, which is actually, believe it or not, a good thing. I'm just hugging your facet. Shot. I feel like I'm right there, just ready to go around. There's some. Where do you feel that?
All the way down the heel.
Yeah. Sorry about that. So that's why you're awake, by the way, in case you were wondering. I need your help with that. So there's a lot of bone right there. In your back, right, Sean? Shot. I'm about as low as I can probably get in the foramen right now because of the anatomy, the bones, bone spur. It's all hard. He's definitely got a lot of bone there. Let's go lateral and then AP. So I think what's happening is that bone spur is pushing the needle lateral. And that's why he's getting the L5 nerve getting irritated. Yeah. See, we're lateral. And that's all bone there. That's what I'm trying to do is go lower, but you see that right where the tip is? There's an outline, and the outline goes even more lateral. Do you see that? Yeah, that's a bone spur. That's probably from his fusion. So I'm going to try one more time at this position, and then I'm going to have to reposition the needle one more time, probably. But I'm hitting probably the fusion mass or the residual bone spur that was left. It's probably the tip of the S1 facet that's hypertrophied. Is probably what I'm getting into right now. And that's why I can't get through it or around it. Shot. Lateral. Oh, it will. But I'm not giving up here first. I have to try everything I can at this position. Why does it seem like we lost our alignment there? Yeah. I don't think he's moved. I know you moved, right? You came more south. So did you accommodate with the wag? That's probably pretty good right there. Let's try that. Shot. It's about as low in the foramen as I can get. But if I'm getting pushed lateral, it won't matter. I'll still get to the same point. Anything? Shot. We're right at the back of the disc. We're like literally a millimeter or two away from where we need to be, but we've been getting pushed wide by your bone spurs. Does that make sense? Yeah. Yeah, that's pushing me wide right there. Shot. Let me see if I'm close enough. AP. Ah. Yeah, the bone is pushing me wide. So I'll try this. If this doesn't work, I'm gonna go take a more lateral initial start position. And if that doesn't work, yeah, too wide. I think it's too wide. You see there's that shadow, that double shadow there. That's the facet joint. Fuck. That's my AP. Yeah. Let's go lateral. Let me know if you feel anything again in the leg, okay? Anything? One more time. Yeah, we're too lateral. Let's try to wag it just a little bit and get those. Try wagging about 2 degrees. Pick a side. And shot. Okay. Yeah, it's better. Yeah, we're too lateral. Too lateral. All right, I'm gonna trying to go a little bit more lateral starting position. Is that sharp, or you feel anything there? Shot. Shot. Is it your right leg that bothers you normally?
Recently, yes.
What's more bothersome, your back or your leg? Shot.
80-20 back.
80-20 back. And what goes on with your right leg that you don't like? Shot.
Toothache pain.
Huh?
Toothache pain.
Oh, toothache? So it must be getting like, is it getting more frequently like that or what?
Yeah.
Shot. Do you have your operative report from New York?
It's in the file, yeah.
That's the one from 2011.
Yep.
That's the surgeon that put all your hardware in?
Yes.
Do you have that report?
Was sent to you guys, yeah.
Okay. Shot. Anything now?
Nope.
Your leg's fine?
Yep.
It's looking better. All right. If we can't get this disc, there's no point in doing the rest of the surgery as a laser. I would just abort. And we would need to do it open. That's my recommendation. Okay? Because this disc is like the most important one to fix your leg symptoms. And the problem is I'm getting pushed wide by the bone spurs that are there. Does that make sense? There's no strategy I have besides what I'm doing right now that can fix that. I don't have a way to fix that. So I'm going to use everything I can do to be able to do this, but if we have to abort it, unfortunately that's what we're going to have to do. You know, rather than, obviously I don't want to risk damaging your nerve. Shot. All right, so I feel like we're rotated a bit. Let's try to, you can see the screws are not symmetric. I don't know if that made it worse or better. I think that made it worse. That's pretty good. So yeah, even there, we're kind of lateral on the pedicle. I'll try. Are you feeling anything? So the problem I'm having, I can fix your back and leg issue, but I don't know that I can do it with the laser surgery. Because I'm hitting these bone spurs that are huge that are blocking my access to your disc. Let's go lateral. Huh? You understand what I'm saying?
Yep.
It's like solid bone right here. This stuff has to be drilled away. And the only way to do that is with open surgery. I'm going to try to just come a little bit further south and see if I can't get in, but just lay down. Shot. No, we're right there, but I think we're just too lateral. Let me just see. Let me know if it hurts, okay? No. I just keep hitting bone. It's like perfect trajectory, but the bone is just deflecting me. Down your leg? Yeah. All right. I'm going to have to stop. Okay? I'm not going to hurt you, and there's just no safe way for me to get into your foramen and your disc. So, yeah, I've never injured a patient with surgery, and I don't plan on making it the first one. But I've tried at least, probably almost 10 different, starting points, and there's no safe way for me to gain access to that disc at 5-1. And if we can't do 5-1, there's no point in doing the other levels, because if I have to bring you back, I think 5-1 is your most symptomatic level, so it's going to need to be dealt with open surgery. And I honestly think to do open surgery, I got to take all your other screws and rods out. And if I'm doing that, I can fix the other areas while I'm doing it. There's no point in putting you at risk, surgical risk, for doing the other discs when I can fix it with the open surgery at the same time. You understand what I'm saying? So, I'm sorry, but there's nothing I can do short of causing you, really bad nerve injury, which I think would be the wrong thing to do. I'm sorry I couldn't get it. Gonna have to abort. Well, folks that are watching, this is real reality TV for surgery. Unfortunately, this is what happens sometimes. It's very rare. Probably 1 in 100 patients that I can't get into the disc. All right, we did not make an incision. You just have some little holes back there from me trying to get the needle in. We'll get you out of here and we'll talk in recovery, okay? All right. We have to abort due to anatomical consideration is what it's called. Okay. And large bone spur, deflecting needle, unable to access. Yeah. I'll come over to the conference room in a few minutes.
So why would they not have taken out the disc? Why wouldn't they have put cages in?
Yeah, so somebody's asking me why they didn't take the disc out. It's, in my opinion, the wrong way to do it, but there are many ways to do fusion, and there's no one right way that's accepted by everybody, so everyone does it their own way. If you don't take the disc out, they're going to end up still having pain. But a lot of doctors don't understand that, so they do it that way. I don't agree with it. Results are not as good, but yeah. All right, I'll be there in a few minutes. Okay, Dr. Deuk here, and I just left the operating room. We had to abort the surgery. Abort is such a horrible word, but it really means we could not do the surgery. We had to stop, and the reason we couldn't do the surgery was not because the patients had a fusion before, because we've done Deuk laser disc repair on patients who've had fusion before. It's because there's a particular bone growth that is on the right side that blocks the needle from getting to the right position. I told you all this before. I make these surgeries look easy, but the reality is that there's a very specific path with about maybe half a degree of variation, which is very, very small amount of variation. It's kind of like driving a car that's 4 feet wide through a hole that's 4 feet 2 inches. You have to be perfect with your trajectory, and I've tried multiple trajectories, and I was not able to get the tip of the needle to enter into the disc herniation in the foramen, and it kept getting pushed wide, and when it goes wide, it hits the nerve root. So if I did not abort the surgery, I would have just literally cut the nerve root in half during the surgery, in which case he would not be able to move his leg. Now, I've never done that in 20 years of operating as a neurosurgeon, and I don't ever want to do that. I'm not going to start today. So giving somebody a nerve damage during surgery is really unacceptable in my mind as a neurosurgeon. Now, is it a known risk? Yes. Have other neurosurgeons done it to their patients? Yes. But for me, I'm a bit of a perfectionist, and I won't create a new problem for a patient knowingly that is a major problem, not even a minor problem. And you have to weigh the risk with the benefit. It really is what it comes down to. The patient did not sign up for me to damage their nerve and fix their back pain. That's not the agreement. The agreement was fix their back and leg pain and really do everything you can to avoid a complication. So damaging the nerve would have been a complication. If I had gone through with the surgery, I would have damaged the nerve. I would have cut it in half. He would have a foot drop as a result of that injury. In other words, he would not be able to pick his foot up as he's walking or, running, and he would lose that function, and that's for the rest of his life. So that's a very bad complication from spine surgery, very, very bad. I've never had it happen, and I would never want it to happen to a patient. So the truth of the matter is, as good of a surgery as the laser surgery is, people ask me, when can you not do the laser surgery? This is the situation right here, where I cannot safely navigate to the herniation, through the foramen, to do the disc repair. And that's exactly right now, where the key word is safely. So, we could talk about this all day, and I don't think any surgeon I know would ever knowingly give a patient a motor or sensory deficit by damaging a nerve root just so they can say they did the surgery. Are there surgeons that would do it? Perhaps, but I truly believe most surgeons try to do their best for their patient. Unfortunately, it's just not good enough most of the time. But when a surgeon knowingly giving a patient an injury is a completely different ball of wax. That's something I'll never do. And so for me, the decision is easy. I don't do the surgery. I don't get paid. And I would rather not get paid than to harm a patient. And so that's the way I believe all doctors should be. That's the way my father was as a doctor. That's the way I'll always be. I'll never compromise. But as a result of that philosophy, it results in situations where we can't do the surgery. Yes? Yeah. Put some pictures of the attempt. Yeah, thanks. So, long story short, aborting a medical procedure like this is not the first time in the world it's ever happened. Surgeons get into situations where they do have to abort. And for me, with the laser surgery, this is probably in 13 years, I would say the 5th time I've had to abort a surgery. There's been 2 times in the neck and probably 3 times in the lower back. And it's always due to the anatomy of the patient. Their specific anatomy is just not conducive with performing the surgery safely. So I don't know if that makes sense to you all, but hopefully it does. There's really not much else to talk about except that if this patient allows me to, I can fix their spine with an open surgery. With an open surgery, I would go through the middle of the back, and I would get down to the spine, expose all the hardware, remove it, and then I would open up the neuroforamen at L5S1 to decompress the nerve root, which we know is being pinched. And then I would clean out the disc, put a new spacer in there. I would also want to decompress at L34 and L45 and possibly put a spacer in there as well, most likely, and then put in screws and rods again. So basically, this patient would have an extension of their fusion to 1 level below L5S1, basically, with an interbody cage put in at 3445551. Would that surgery fix this problem? Absolutely, I think it would. I think it would take away 90% of his back and leg pain, probably 90 to 95%. Can it be done safely? Yes, 100%. Have I ever had to abort that surgery? Absolutely not. That is the fallback surgery. That's the surgery that I think should be done if the laser surgery is not able to be done. And the laser surgery not able to be done clearly is less than 1% of the time, because I've had to do it 5 times in 1,000 cases, so it's about 0.5% incidence. That being said, yeah, I'm not willing to create a problem for a patient during surgery that I think is unacceptable complication to give somebody relief of their back and leg pain. It's just not right. Yeah. All right, I'll take some questions if the audience has any.
Did the patient try a stimulator?
So somebody is asking, Dr. Deuk Majan, did this patient happen to try a spinal cord stimulator before the laser surgery I attempted today? The answer is yes. This patient has had 2 spinal cord stimulators implanted already, not by Duke Spine Institute, but by other doctors in New York. And neither spinal cord stimulator worked. So they had 2 spinal cord stimulators, 2 prior fusions in their lower back, and they're still in pain. Like I said, I can fix this gentleman's problem, no problem at all. The only issue was he and I both wanted to fix it with the laser surgery rather than another open fusion. So that's what we attempted to do today. The attempt failed. But he's already had 2 spinal cord stimulators. Neither of them worked. He's done with everything. He wanted the laser. I wanted the laser for him to work. Unfortunately, it didn't work. And so this is that less than 1% of patients going in for laser surgery at Duke Spine Institute where they won't get it. And I tell people in their consent form, there's a chance that I won't be able to do the surgery. So it's all documented. It's unfortunately something that every single patient that has surgery has to be prepared to live with, is the fact the surgeon may come out and tell you at the end, I'm sorry, I couldn't do what I wanted to do. And for me, I can still fix this problem very easily, but it's going to be with open surgery. So why should I harm him in the process of trying to do a less invasive surgery when I know that I could do an open surgery safe and effective without complication? So that's really what it comes down to. This is where it's important that your surgeon use good judgment. And this is where it's important you pick a good surgeon to know when they can't do something and not try to force the situation and kill you or harm you badly permanently.
Possibly going from the left side of the disc to get to the problem.
All right, so the question was, can you possibly go into the left side of the disc to get to the problem? The answer is yes and no. Yes, you can go on the left side if there's no bone spur there. But remember, the problem that blocked me on the patient's right side, which is the side they were having their leg symptoms, which is why I always go on the side of the leg symptoms, that problem is actually the facet joint itself combined with the fusion mass and the scar tissue around it. So that same problem exists on the other side. It's no different. It's identical. Generally, it's mirror images, okay? So what blocked me on the right will block me on the left. But that's not the important thing, to be honest with you, because I'd still try. But the fact of the matter is the patient's leg pain is on the right side. So even if I was successful at getting the needle into the left side foramen and disc, I would not be able to decompress the nerve root on the right side, because you have to be on the right side to decompress the nerve root on the right side. So going to the left side would not solve his leg symptom problem, okay? And that's one of the main reasons he's having surgery is his leg. He wants to get rid of that toothache pain in his leg, and I can get rid of it, but it's going to take open surgery. So yes, I could go on the left side. Most likely I won't be able to access the disc space because of the same reasons as the right, because they're identical mirror images. But if I was able to access it on the off chance, then I still wouldn't be able to treat his right leg pain. And I wouldn't be able to treat the annular tear on the right side because I'd be on the left side. Can't get over there. Got a long question. All right, let's do our best.
All right. I was fused in my cervical C5, C6 in 2013.
Someone with a cervical fusion, 2013. Keep talking.
Have disc problems now above and below fused area.
Adjacent segment disease with disc problems above and below.
3 surgeries in lumbar. Last was 2008 fusion, which is very similar to this gentleman.
3 lumbar surgeries. Last was a fusion in 2008.
Osteoporosis, bone spurs, and degenerative disc disease, very bad.
Okay, they have degenerative stuff with osteoporosis.
Just had another round of lumbar injections in the last few months, and they did nothing for me. I have terrible cervical pain between shoulders and down my left arm, as well as in my SI joints, pain down left leg, and numbness down right leg to foot. I've been told my cervical C2 disc is bad, in need of SI joint fusion on both sides. I think my lower back pain is from my SI joints.
All
I'm
right.
extremely tender on both sides of my lumbar scar. Feel we should be able to help.
All right, so we have somebody watching that is, sounds like, I don't know their history entirely, but it sounds like they're having problems in their neck and lower back both due to disc injuries, which are, again, common in the population, but they tend to run in families genetically. I see it a lot, people with neck problems, back problems. If it's genetic, they typically have fathers, mothers, uncles, sisters, brothers, cousins, children, etc., with spine problems. So very, very strong familial component. Long story short, we can definitely help you. I would strongly recommend, and I mean strong as in 10 out of 10 recommendation, come here and see me before you have SI joint fusion. You know how many SI joint fusions I've done in 20 years? 0. The reason is simple. It doesn't mean that they're not necessary sometimes, but the extremely rarely necessary. Unfortunately, the companies that make those fusion devices for the SI fusions are pushing them on all the doctors and patients because they want to make money. They want to sell those things and make billions of dollars. That is not a reason to do an SI fusion. You do an SI fusion when a patient has sacroiliac joint dysfunction and their pain is coming from the SI joint, and it doesn't go away with conservative treatment like injections and therapy or rhizotomy. So before you go having your SI fusions, please come see me. Number one, I don't think, just based on statistics, that your SI joints are the problem. Number two, if you have adjacent segment disease, which is what you're saying you have, which is a problem with the disc above and below the fusion, that's easy to fix with the laser surgery. Well, you didn't just watch, which I wanted to say you just watched, but you didn't because I didn't do it. But it's easy to fix with the laser surgery generally, or I can fix it with an open surgery. But your problem is definitely fixable. I just need to see your pictures, your MRI, CAT scan, and I want to see you. I want to see where your pain is. I need to see it it's called topographically. So we'll pick a word for the day. The word will be topographic. Topo means like on a map, basically, like where on a map, location. Topo is location. Graphic is where you kind of show exactly where something is. You're graphic about it. So you're visually orienting to a specific location. So topographic means you need to orient me to where your pain is with your finger. That's what I ask all my patients that come see me. I think it's one of the most important things I do to evaluate a patient's pain to figure out where it's coming from is I ask for a topographic representation of their pain. And what that means is the patients will stick their one finger on the one spot that's the worst pain. That tells me so much information, and it helps me to fix people's problems properly. So we can definitely help you, whoever's asking this question about the prior fusion, adjacent segment disease, and we can definitely help you. I just need to see you on a camera or in front of me so I can figure out where your pain's coming from. And then I also need a CAT scan, MRI, and possibly x-rays and a nerve test. With that information and a physical exam, I have the ability to fix your problem. I really do. So please come see me or talk to me, have your MRI reviewed. Don't go have an SI joint fusion. Strongly recommend against it. There's so many people getting SI joint fusions now that don't need them because they're being They're being pushed, unfortunately, by the companies, by the doctors. And a lot of times the doctors don't know where the patient's pain's coming from because they don't know how to figure it out. At Deuk Spine Institute, we're able to figure out where your pain comes from. We do that by using diagnostic imaging, MRI, X-ray, EMG, CAT scan sometimes, physical exam. You show me where the pain is, where it goes. Also, I rotate joints, press on joints, twist joints to see if they cause pain. Same thing with muscles. And then finally, we have a very secret weapon at Deuk Spine Institute. It is literally one of the most powerful weapons in the world in curing back and neck pain, and that is called a diagnostic block. A diagnostic block is simply a procedure where we will put numbing medicine called Novocaine into a specific joint or muscle or around a specific nerve for one purpose, to see if numbing that area takes the pain away. It's important because if you can numb a joint and take someone's pain away, you know that that joint caused their pain. See? It's a relationship, a causal relationship you're looking for. So if you know which joint caused the pain, then you can go in and fuse that joint or remove that joint, or you can repair the joint. So in the case of the Deuk laser disc repair, we would repair the joint. Next question. That was our last question. Again, I apologize. We were not able to do the laser surgery today, but I honestly believe in my heart that it's the right thing for the patient, not to give him permanent weakness in his leg. And he's going to, I believe, hopefully come back and get the open surgery done, which is the right thing to do. It's very easy to fix his problem with open surgery. It obviously, when I say easy, the surgery itself will be hard because of all the scar tissue and bone and screws and rods, but easy as in it's a no-brainer decision. The patient's getting worse. I can fix their problem, but it's going to take open surgery. So that's what I believe is the right thing to do. And honestly, if I had to repeat this again with another patient, if I had to see another patient that had a fusion before, I would probably recommend doing it exactly the same way we did it today. And the reason I say that is because I've had many patients with prior fusions where I've been able to fix the adjacent disc with the laser surgery. This just represents an unusual situation where we couldn't, and there was no way to predict it ahead of time. So we did the right thing for the patient in scheduling the surgery and attempting it. We did the right thing for this patient in aborting the surgery to protect that patient's body and not injure it. And I think the right thing to do is to move forward and do the open surgery safely at Deuk Spine Institute. So hopefully we'll have the opportunity to do that. Some patients understand, some patients don't. I can't fix that. Some people will be angry with me because I couldn't get it done. That's okay. I can live with that because I believe I've done what's right for the patient. And, we'll see what happens. We still have one more laser surgery. It's a 2-level disc repair, Deuk laser disc repair, coming up in about 30 minutes. So sorry again, but hopefully we'll see you later.